Good. Yeah. So again, welcome everyone to this topic. These sessions, we want to try and do them every Tuesday. In the group, it's a mixed group of people. It's people who have no idea about HIV and AIDS who are just starting. There's people who are NIMART trained, and there's those who are already mentors and mentoring other people. So I believe that as we share our experiences at the end, it will be a value add for everyone. So just to say for today is just welcome and introduction, which I have already done. Then we're gonna look at the case of Tumelo, and then at the end, I will then open up your mics, and then you'll be able to engage in a question and answer format. But like I said, write down your comments, your notes, where you need clarity. You can also type in the chat box, which I would then go through towards the end of the session. Just to say that I'm part of the Aqua Training School, and we have a vision for a better society where everyone achieves their full potential. Our key approach is to support healthcare workers to always be up to date, to have the adequate knowledge and skills to be able to care for our patients and communities. We are accredited by the HWCTA. These are some of the programs, specifically the ones that are targeting nurses, from NIMART to clinical mentorship, adult primary care, which covers chronic diseases, 20 chronic diseases and 40 symptoms, IMCI for the management of children, dispensing, leadership and management, and soft skills. So if you are interested in some of these, do send us an email or visit our website for registration, and we will be happy to help you. So let's look at today's case. It's Tumelo. Tumelo is, I think we missed the for some reason there, it's a mistype in terms of the age, but Tumelo is a 34-year-old a female patient who is diagnosed to be HIV positive, and she is 8 weeks pregnant, right? So it's a young lady who's 34, she's 8 weeks pregnant, and she has just been diagnosed to be HIV positive. We have her CD4 count, which is 0.2, so it's quite low, and she was treated for angular cheilitis 2 weeks ago, and you are now screening her to assess whether she qualifies for opportunistic prophylaxis therapies. So we want to check whether she is eligible or not. So there are the first 3 questions we have to answer. The first one says, what questions would you ask this patient today? And then are there any assessments and tests that you think need to be done? And then what is the WHO clinical stage for Tumelo at this point in time, right? So we are dealing with a young person who has just tested positive. She's pregnant. She's got a very low CD4 count. Already she's starting to become sick because she was treated for some opportunistic infections. And as a start, we want to look at whether she qualifies for some opportunistic prophylaxis or not. So let's go on. So if you look at prophylaxis therapies in South Africa, there's 3 that are very critical, which are meant to prevent, infections, but also to prolong lives for people who are at risk. So if you look at HIV positive patients, they are likely to die from infections, whether it's diarrhea, pneumonia, malaria is also a problem, but there's also specific infections like toxoplasmosis, which is a parasite that affects, the brain tissue. And there's PCP pneumonia, so it's a type, of pneumonia where people can become sick and deteriorate very quickly. So we give this Cotrimoxazole prophylaxis, which is what is traditionally called Bactrim, to manage or to prevent our patients from getting such infections. We have TB preventative therapy where we use some of the anti-TB drugs, not necessarily for treatment of active TB, but for the treatment of what we call latent TB infection. And isoniazid is one of those. I know nationally we're about to finalize the guidelines, and there's pilot provinces which are going to look at other regimens for preventing TB. Then we've got another important one, is called fluconazole prophylaxis therapy, which is meant to prevent people living with HIV and AIDS, specifically those with CD4 counts less than 100, right, from getting what we call cryptococcal meningitis. So we know that before people get a meningitis, they would have this fungi in their blood. So we are able to detect it early. If the test comes back positive, then we would then consider those patients for this prophylaxis therapy. So let's quickly go through these three prophylaxis therapies. So the first one is Cotrimoxazole prophylaxis therapy. What you have towards your left is the different age groups, right? And then we deal with when to start which prophylaxis therapy. And also we deal with when to stop a specific prophylaxis therapy, right? So if we look at our patient, it's an adult. We said she's 34 years old, right? So she would be eligible for Cotrimoxazole prophylaxis. She is pregnant, and Cotrimoxazole is safe for use in pregnancy. So we should be able to help her with that. Her CD4 count is 2, which is generally below 200. So she qualifies for that. And then we are still going to assess in terms of WHO staging to say which stage does she belong to. However, the eligibility criteria for Cotrimoxazole prophylaxis is that if your CD4 count is less than 200, or we are dealing with a clinically symptomatic patient, right? Stage 2, stage 3, stage 4 patients should be on Cotrimoxazole, and we can only discontinue it as soon as their CD4 counts go up more than 200 cells per microliter, right? And the standard dose is Cotrimoxazole 960 milligrams per oz daily, and depending on the strength of the drug that's available, it's either the 960 tablet, it will be 1 tablet daily. If they have the 480 tablets, then the patient will then be given 2 tablets once daily. Now, there are, in terms of now coming back now to the next prophylaxis, looking at TB preventative therapy, we have an approved algorithm which says whenever you have an adult or an adolescent living with HIV and AIDS, right, one of the first things we need to try and do, right, is to screen everyone that we meet. All our patients must be screened for TB. And we use these key 4 questions. Current cough, which means cough of any duration, whether there's fever, weight loss, or even night sweats. If a patient has any of these, we then need to investigate them for TB and other conditions, right? If TB is confirmed, we would then treat for TB. If there is no TB, we would consider them for TB preventative therapy at a later stage. We generally wait for 3 months. If they have another diagnosis, which could be COVID or any other form of pneumonia, it needs to be treated as needed, right? Now, let's say we screen a patient and the patient does not have any of these symptoms. We then need to assess whether there's any contraindications to preventative treatment, right? So when we ask, the first question which we are saying for Tumelo, which questions do you ask? You have to talk about, your assessment in terms of TB screening questions, because these are questions you need to ask. You also need to assess whether she's got any contraindications to preventative treatment, which we will cover now. If she has contraindications, we have to avoid TB preventative therapy, which is INH at this point in time. If she does not have symptoms, she also doesn't have contraindications, we would then give her the prophylaxis as needed. All right. So that's quite positive. Now I want to introduce a very important change in the guidelines, which has changed just in the month of May. So in terms of now screening and assessment of pregnant women, in terms of whether they are eligible for TB preventative therapy or not. So remember our case, Tumelo, she's pregnant, she's 34, she's got a CD4 count of 2. So if for non-pregnant patients and people, we just rely on TB screening, right, to screen them. But with our case, who is pregnant, you would then look at the TB screening as the first entry point. Those who screen negative, you then do a sputum gene expert, irregardless, right? Regardless of the outcome of the screening. Whether if the screening test is positive, you do a gene expert. If the screening test is negative, you still do a gene expert in all HIV positive pregnant women, right? And then this is a new change, right? If you read the original HIV guidelines, we were saying women who are pregnant would only be eligible for TB preventative therapy or INH prophylaxis when the CD4 count is less than 100. So now further research, has been, research results have been released, and there's now an official communication from the Maternal and Child Health Unit at the National Department of Health that pregnant women with CD4 counts less than 350, not 100 anymore, but 350, are eligible for TB preventative therapy. So for our case, Tumelo, her CD4 count is 2. She would have qualified anyway, whether this was 100 or 350. But please note the new change and make sure that you implement the current available evidence around access to TB preventative therapy, right? Now, if someone you have screened them and they are eligible, you need to still assess whether they fall within a group that should get INH prophylaxis or groups where this prophylaxis should be avoided, right? So if you look at it here, all HIV positive non-pregnant adults should be initiated on TB preventative therapy. Pregnant women who have a negative screening test and a negative gene expert with a CD4 count less than 350 should be initiated. A patient who was a TB patient and completed treatment, right? So they were diagnosed with TB, they completed, they were cured. They can still be initiated, and there's benefits for them to get INH so that they don't have this repeat TB that keeps on affecting them. Now you need to assess for other things. For example, if someone is a TB suspected case, right? We do not want to give them TB preventative therapy. TB preventative therapy is for people who have negative TB symptoms. And then here you can see pregnant women with CD4 counts higher than 350, we don't give INH. We only give it to those with CD4 counts less than 350. Patients who've got liver disease, patients who have had some adverse events to INH and excessive alcohol use. So these are the kinds of questions you'll be assessing and asking questions for your patient to assess whether they are eligible. If someone was on isoniazid preventative therapy before for a year and they completed it, but now today they are living with someone who has TB, so someone who has just been diagnosed, so they have a contact at home, they are eligible to be given INH prophylaxis. So that's very, very important for us to note, right? So in summarizing TB screening in pregnancy, all pregnant women would be screened for TB. Those who have symptoms would then be investigated for TB. And if TB is confirmed, they are then treated. If TB is excluded, right, like is the case here, we wait for 3 months before we can give them the prophylaxis. However, if you screen someone for TB and they are eligible in terms of the screening test is negative and they do not have any contraindications, alcohol abuse, liver disease, and their CD4 count is not too high, you can then prescribe INH preventive therapy as needed, right? And then this is the dosing. So remember, for Cotrimoxazole, we said 960 milligrams per ounce daily. For isoniazid, for all HIV positive patients who do not have TB symptoms and who do not have contraindications, you give them 300 milligrams daily, but you can also calculate it using the weight, which is 5 milligrams per kg per day. The duration is 12 months, right? Not more than 12 months. And it's given with pyridoxine 25 milligrams per ounce daily to prevent peripheral neuropathy. Always remember to support patients because, as you can see, they're going to be taking a lot of tablets early on. Whilst they're still trying to understand their HIV diagnosis, we also give them quite a number of tablets, right? So we covered Cotrimoxazole prophylaxis therapy. We just discussed TB preventative therapy, specifically INH prophylaxis therapy. Now I want to then take you through fluconazole prophylaxis therapy, and let's look at what is it that we need to do for our case, Tumelo, right? So in terms of fluconazole prophylaxis therapy, you have a patient who tested HIV positive, a CD4 count is done, and the results come back to be less than 100. So they have a CD4 count of less than 100. So going back to our case, her CD4 count is 2. Therefore, we need to do a cryptococcal antigen test. And there's a confusion sometimes. Some nurses think this is a test that you do in the CSF. No. Here we are talking about a test that you're going to do from blood. You take blood in that red, orange tube lab bottle. You send it, for this test. In the private sector, you have to order it. In the public sector, when you send your specimen for a CD4 count and the lab, as they process, the CD4 count is less than 100, they will automatically do a cryptococcal antigen. So your CD4 results will come already with a crack antigen having been done, right? So Tumelo, now we need to do this crack antigen and wait for the results, right? If the results come back negative, then we just start her on ART. She doesn't need fluconazole prophylaxis therapy. If her crack antigen comes back positive, right, we need to contact the patient urgently. We need to screen her for meningitis in yellow. So you go to the yellow box there. So we are asking ourselves, is this patient symptomatic? Does Tumelo complain of a headache or confusion? No, there's no complaint of headache or confusion. So we are fine. She's asymptomatic. Though she has a positive crack antigen, she is asymptomatic. We check for special situations, and in our case, this is going to be important because here it says special situations. If it's a patient who has had cryptococcal meningitis before, Tumelo, no, she has never had crypto. Is she pregnant? Yes, our patient is very pregnant, right? But she does not have liver disease. So in pregnancy, this is a very complex discussion we need to have with Tumelo, because one is that she does have a very bad condition, which if left untreated, she might not see her baby, right? We might never get to see her and the baby because in the next few weeks or months, she will get a meningitis and then, something horrible might happen to her. If we give her fluconazole, as is the case, there's implications for the baby, right? Fluconazole affects the skeletal, the bone system of the babies, and they are sometimes born with very serious deformities, and so on, right? So the counseling, it will be a balanced counseling where we give her fair information about cryptococcal meningitis and what would happen, and why we believe that if she takes it, it might affect the baby. But the recommendation from us as healthcare workers at this point in time is that we want to treat this cryptococcal meningitis because we want the mother alive. That's our first priority. It's a recommendation, but it's a shared decision between the health worker and the patient in this instance, right? So I'm noting your comments on the chat box. We will reply as soon as we go through these slides. So in terms of the yellow bit, the symptoms, our case is asymptomatic. If she's got symptoms, right? If she was having headache and confusion, we would just give her a steady dose of fluconazole and refer her to a hospital, right? But now our case, her CD4 count is 2. She's asymptomatic. Therefore, she qualifies for the prophylaxis, not the treatment in blue. The blue is the treatment wing for those who have symptoms. She doesn't have symptoms. Therefore, we will give her fluconazole 800 milligrams daily for 2 weeks at home. Then after 2 weeks, we reduce the dose from 800 milligrams to 400 milligrams for 2 months. Then after 2 months, we change it to 200 milligrams daily, right? I'm gonna share these slides with you immediately after this presentation. You can take snapshots, but I will share all this information for your ease of reference, right? So she will get 800 milligrams daily for 2 weeks, 400 milligrams daily for 2 months, then 200 milligrams daily for at least a year until she has a CD4 count above 200. When to start ARVs, right? So for the wing, for the prophylaxis wing, we can only start ARVs when she has completed fluconazole for 2 weeks, because the liver generally cannot cope with taking ARVs and fluconazole at the same time. Now, this is a very high dose of fluconazole, right? If she had a meningitis, we'll have to wait for up to 6 weeks before we start ARVs. So remember, she's pregnant. It's a very, like I said, it's a simple case. If you look at it, she just came there, she's positive, she's pregnant, you know, but now her CD4 count is 2. You do a crack antigen, it's positive. It complicates how you need to approach her, because in the PMTCT world, she needs to start as in today, but now we have to start her on a prophylaxis, which when given with ARVs at an early stage might even make her a bit sick, you know. So this is the algorithm. You know, these 3 slides, Cotrimoxazole, isoniazid, fluconazole, you know, they are important, and we have to make sure that our patients get these because they prevent deaths and the burden on the health system. So we are supporting. So there was a question which said, what is the World Health Organization stage for our case? Just to take you back to the case, right? If you remember, she's 34 years old. Sorry, we omitted the age there. She's 8 weeks pregnant. Her CD4 count is 2. Angular cheilitis. She's got angular cheilitis. And this is the mistake we make. Some people, they see a CD4 count of 2. They're like, no, she must be stage 4. No. Remember, WHO clinical staging, we don't use blood results, viral loads, and CD4 counts to determine the stage. What do we use? A specific clinical condition that the patient has. So if she was asymptomatic, she'll be stage 1. Stage 2 is mainly, you know, things limited to the skin conditions. You can see there's angular cheilitis, right? What is angular cheilitis? Is when you have this whitish materials on the corners of your mouth, right? And it's mainly candida when it starts at the corners of the mouth. As long as it's not in the tongue or hard palate, it is still stage 2. As soon as you have oral candida, it will be a stage 3 condition. If it's now has spread to involve the throat and so on, candida of the esophagus, where now the patient has difficulty in swallowing, this would be a stage 4 condition. So if you use candida to stage a patient, stage 1, no symptoms, no candida. Stage 2, they have candida limited to the corners of the mouth. Stage 3, it's now progressing. It's in the mouth, the hard palate, they've got sores in the mouth, the tongue. And then stage 4, you've got candida where patients have difficulty in swallowing. So in terms of answering the clinical stage question, we are dealing with an HIV positive pregnant mom who is stage 2 with a CD4 count that is very low, and that CD4 count is 2 also, right? So just remember, we don't use a CD4 count for staging our patients. So Tumelo now meets the eligibility criteria for prophylaxis therapies and has no contraindications to her TB preventative therapy, right? Her crack antigen is positive, right? Now remember, she had a CD4 count of 2, which is less than 100. We said we must do crack antigens for all patients with CD4 counts less than 100. So we have the result, it's positive. She has no symptoms of TB, which is good, or meningitis, and then no allergies to sulfur. Remember, people who have sulfur allergies, they might get the rash from Cotrimoxazole or Bactrim. So here's a question. What do you do next? Drug names, doses and frequency, and follow-up schedule and stopping plan. I mean, we have already discussed it. So it's Cotrimoxazole, 960 milligrams per oz daily. You give it until her CD4 count goes to be above 200. She has no contraindications to TB preventative therapy. She does not have TB symptoms. Therefore, isoniazid 300 milligrams daily per oz for 12 months with pyridoxine 25 milligrams per oz daily. You see? And then fluconazole, yes, she qualifies. Why? Because her crack antigen is positive, right? So don't look at the CD4 count and start giving fluconazole. You must wait for the crack antigen. If it's positive, she qualifies for the prophylaxis because she doesn't have meningitis symptoms. She does not have. So there's no need to refer her. You would say then fluconazole 800 milligrams per oz daily for 2 weeks. Then you change it to 400 milligrams per oz daily for 2 months. Then 200 milligrams daily for at least a year. Remember, they need support, counseling. It's a lot of tablets. You have not even prescribed ARVs. This is just prophylaxis. Already it's a lot of tablets. She needs to cope with her pregnancy. She needs to cope with the HIV status, the risk that the child might be born with HIV, the risk that the child might be born with malformations from fluconazole. So don't forget that discussion with the mother. And then also the ARVs, which she has to take for life, right? So it's a very complex problem. So in terms of HIV, how do we manage her? Because we have to plan, around that. So let's see. So remember, she's pregnant. Don't rush into HIV care. Go to your bank plus and your basic antenatal care services. Make sure that you appreciate that we are dealing with a pregnant mom. So we must do a full physical exam, risk, checking her urine, dipsticks, sugar in urine, blood pressure measurement, supplements, calcium, iron, the whole RPR, RH. So the whole thing around pregnancy has to be done by the clinician who's seeing her. Don't say, I'm not a midwife. No, open your adult primary care guide. On these pages, you'll get a very nice advice on everything that needs to be done. She was diagnosed HIV. You just need to make sure that you have a confirmation of this HIV test. And then if she had tested positive, we would be retesting her, ask her about her partner and other children she might have that need to be tested, and then we need to make sure that she's supported, as needed. In terms of other things, Cotrimoxazole, INH, and fluconazole, we've already discussed that. She needs it. Her CD4 count, we know it. It's 2. TB screening, we have already done. She's got angular cheilitis, so you can give her Dactarin oral gel or even nystatin, any antifungal solution that is safe, you give it to her. Counseling and support is very important, and you need to examine, take proper history, make sure that the tests that need to be done are done, and then you give medication when you believe that you understand what's going on with her. These are some of the baseline in terms of the HIV side of things. She has to be taught around the drugs and the side effects, TB screening, how to take the drugs, safer sex during pregnancy. because there's still a possibility that, you know, the couple, the husband is is negative. We will discuss this topic also. I have a nice presentation on it. Serodiscordant couples, she's already pregnant. Staging we have done. We need to do hepatitis B, a pap smear, preferably 6 weeks after delivery. Remember, viral loads in pregnancy is not 6 months, right? The first viral load in pregnancy is done 3 months after starting ARVs. So just remember that. HB will be done, and then a creatinine level will be done. In pregnancy, we don't do a creatinine clearance. We do a creatinine, and if it's abnormal, when the creatinine is above 85, well, then we know that it's abnormal. So you do these baseline tests, right? Now we have to initiate her, you know. As simple as we started with this case, it seems like it's becoming complex. It is all right, because now we have started her own fluconazole prophylaxis. Look at the first step in initiating ARVs. We are saying determine the time frame. Is this patient a person you can initiate today? Hey, yeah, there's competing things. She's pregnant. PMTCT says same day. But now she's starting fluconazole, a high dose, which if given with ARVs might create problems for her. And the other pressure we have, her CD4 count is 2, so it's very low, right? So in an ideal world, what you do, you give fluconazole for 2 weeks, and then at 2 weeks, you then start her on ARVs, you know, and then we move on like that, right? Luckily, she's still early in her pregnancy, 8 weeks, so we still have time in terms of getting her to be suppressed before delivery. Alternately, we would then give her AZT monotherapy as a BD dose, AZT 300 milligrams BD for these 2 weeks together with fluconazole. And then after 2 weeks, we then stop the AZT and give her the full ARVs. But she's not a patient who can be initiated same day, right? And then which regimen we will discuss. So once you say this is a patient who needs to be initiated whenever the timing is the correct timing, then is this a patient who has been on ARVs before? The answer is no. Therefore, she's for regimen 1. Which 3 drugs? So preferably we want to give patients with low CD4 counts like her, you know, a very good regimen, a robust 3 drugs that would suppress, you know, the virus tomorrow or as soon as possible. So TLD, tenofovir, lamivudine, and dolutegravir should be what we want to give, but there might be issues because if she's got no kidney problems, tenofovir is fine. Then lamivudine, generally safe. Now, remember, she's 8 weeks pregnant, right? 8 weeks pregnant. She's borderline. You know, we want to avoid dolutegravir in the first trimester, especially in the first 6 to 8 weeks. So she's like borderline. But remember, what will happen with her is that she's 8 weeks. We give her fluconazole for 2 weeks. After 2 weeks, she will be 10 weeks at the time when we need to start ARVs. So maybe dolutegravir can still be the best drug regimen for her, right? So remember that. So we're going to have a lot of discussions, I think, on this case. As you learn, there's a lot of things. Tumelo is becoming more and more problematic. So Tumelo now is back for the 2 weeks initiation. You didn't initiate her. You said, I'm going to give you fluconazole for 2 weeks and then I will initiate you after 2 weeks. Now she mentions that she's been coughing with loss of appetite and night sweats. Oh my God. It's quite common, this one. I can tell you, most people, you start them without symptoms. Very soon they get symptoms and then, you know, and then her baseline tests were all normal. So all those creatinines and stuff, everything is normal. There are no problems. So what do you suspect is happening? So I suspect that 2 things is that maybe she's got a TB because look, there's cough, loss of appetite, and night sweat. So I'm suspecting that there's TB. What are your concerns? My concerns are that she's becoming a challenge because She's on isoniazid prophylaxis therapy, and now she's developing symptoms of TB. So we need to stop the INH, right? It's not meant for people who have symptoms, and we need to investigate these symptoms by collecting a gene expert again, and then looking at what the results are going to look like. So that's going to be an interesting thing. So if you look at initiating ARVs in pregnancy specifically, we prefer this regimen, right? TLD, tenofovir, lamivudine, and dolutegravir. This is preferred. It must be started same day unless you suspect one of these to be happening. And we are suspecting that she might be having TB. So we are now a bit worried, right? So it means we can't start her again. She's 10 weeks pregnant, and now we think, hey, we need to do other things, you know. But in the PMTCT guide, right, there are rules, you know. All women with contraindication to TLD must not go home without ARVs. They must get something. No one must leave your consultation room without ARVs. You know, you can do whatever test, like a gene expert that you want to do, but we need to try and give her something. So the rule number one, we must screen every woman for TB, regardless of HIV status. Even if she was negative, we would have to screen her for TB. Now, here's the big part about this. So the sensitivity of the symptom screening in pregnancy is reduced. That's why we want to do a gene expert for all pregnant women, irrespective of whether the screening test was positive or not, right? All pregnant women who are newly diagnosed must be screened for TB. All women who are diagnosed to be pregnant must be screened for TB. So that's very important. In the old guidelines, for our case, where now she develops symptoms like this, we would give her AZT, and then we wait for the gene expert results, only start ARVs later. Now that has changed, right? In the PMTCT guideline, just note bullet 3, it's very important. Our new PMTCT guidelines recommend that women with TB symptoms, which Tumelo is, she has TB symptoms, must start ARVs, right? Triple therapy, not AZT monotherapy anymore, right? You can delay ARVs if she's got danger signs, like if she was hypotensive, history of collapse, you know, she was breathing fast, or her oxygen capacity, you know, is very low. So that means Tumelo comes in today, she's a TB suspect, right? We are able to start ARVs and TB treatment the same day in pregnancy, right? As per the guidelines. But then these patients need to be monitored. We need to teach them to say, we are going to give you these 2 drugs at the same time, but please note that should you get your body becomes sore, you've got your temperature goes up, you struggle to breathe, come and see us, you know, as soon as possible, because this is a significant change in how we are used to managing TB. In non-pregnant people, the guidelines, the adult guidelines still talk about you treat TB for 2 weeks first, then start ARVs. But in pregnancy, because we don't have time, right, to waste, we need to get her suppressed. We want the baby to be born without HIV. We would then start both treatments at the same time, but these patients would need to be monitored very closely. So the relationship between HIV and TB is something that we need to master, right? So from the TB side, she was a suspect. Now she's got symptoms. You'll do what we call a TB expert test, right? If it comes back positive, you would then treat her as a TB patient using standard TB drugs, then collect a sputum for microscopy, right? Remember, all gene experts that are positive, you must collect sputum for microscopy. So just remember, we use gene expert or TB expert for diagnosis, but we use the microscopy for monitoring treatment, because we expect someone who's got a 3+ later on after 2 months to have no AFBs in their sputum. So just remember, in terms of TB, That is all that you'll be able to do. And we treat TB with 4 drugs. I mean, TB has not changed. Ne? Rifampicin, isoniazid, pyrazinamide, and ethambutol. These 4 drugs, right? For 2 months. Then after 2 months, we stop pyrazinamide and ethambutol. We only continue rifampicin and isoniazid for 4 months. So TB treatment is treated for 6 months. 2 months is the 4 drugs: rifampicin, isoniazid, pyrazinamide, ethambutol. And then you take those 4 drugs for 2 months. At 2 months, if the smear is now negative, you then can continue the continuation phase with just the first 2 drugs. So that is that, right? Now, depending on the outcome, because we might know whether she's got TB or not, what we will need to do is to then assess women and adolescent girls. If you look at it there, they're asking you, is she pregnant or not, right? We are dealing with a pregnant HIV positive lady. You need to provide information about dolutegravir and efavirenz, fair, honest information. Then you need to make your recommendations. If she's in the first trimester, it's best to use TEE. So what is TEE? It's tenofovir, emtricitabine, and efavirenz, right? If she was in the second and third trimester, you would use TLD, which is tenofovir, lamivudine, and dolutegravir. So in other words, in the first trimester, we want to avoid the use of dolutegravir, specifically in pregnant women. So that's very important. There's another catch there. You see her weight. We said her weight was 34 kgs. So she had a weight of 34. Now you can only use tenofovir when the weight is above 35, you know? So that's another catch there. So we might need to use abacavir with efavirenz and emtricitabine. So it gets complicated, you know, as it goes. Just remember, you need to make sure that, remember, at 10 weeks, dolutegravir is still an option. So in terms of your counseling session, make sure that we don't just deal with the drugs and the virus, you know, try to support, you know, the mother, helping her to understand her pregnancy, you know, if she's pregnant, what are the risks, and whether she wants to fall pregnant again in the future. Even after this pregnancy, is she going to use family planning? You know, what are the risks for both, benefits and risks for both DTG and efavirenz? Help her to make a choice, and then you support her in implementing that specific choice. So we are more of partners. These are the drugs. If you opt for tenofovir, you'll give it as 300 milligrams daily. If you give abacavir, you'll give it as 300 milligrams BD. We prefer daily doses, so that will be 600 milligrams daily. Remember, lamivudine and emtricitabine are used interchangeably. That means that's why we say TLD, which is lamivudine, and then TEE, where we opt to use emtricitabine. It's just the same drug. Then we have to choose for this patient between efavirenz and dolutegravir. Now, efavirenz is safe with TB. It's safe. We don't need to make any dose adjustments. So it's a better drug, and the number of tablets are also better. And then dolutegravir, it's 50 milligrams per hour daily. If the patient has TB, we have to increase the dose to 50 milligrams BD, right? So we need to then, at the end, look at what would be the best regimen for our patient. So let's go back to the scenario and try and summarize the day for tonight. So she's 34 years old, right? She's 34 years old. She's 8 weeks pregnant, right? And she's got TB symptoms. What would be the best regimen? What's your take? I wonder what is it that you have written down as I go through these drugs, right? So coming to these drugs, tenofovir, we could give it, but now her weight is less than 35 kgs. You can only give tenofovir to patients who have a weight above 35 kgs. So we can't give tenofovir. Then abacavir is our drug there, right? Abacavir. with lamivudine, perfect. So abacavir 600 milligrams daily, lamivudine 300 milligrams daily, perfect. Then we have to choose efavirenz or dolutegravir. Efavirenz will be the best option because she's also now at the risk of taking TB drugs. And if she's got TB, we don't need to change efavirenz. So abacavir, lamivudine with efavirenz sounds like a plan, right? We can still use DTG, but then we would need to increase the number of tablets that she takes. She's now 10 weeks or so pregnant, so it's still an option. Though we should probably avoid DTG in the first trimester at all. So if I was to say, what is the best regimen? Abacavir, lamivudine, and efavirenz. That I'll be very happy. More comfortable with a lot of confidence for that regimen without me having sleepless nights, being worried about her and so on. And why again would I want to avoid dolutegravir in the first trimester is because she's also taking that other drug, fluconazole, which is also having problems with babies and pregnancy, right? So just to summarize how TB drugs interact with ARVs, and I'll probably stop here. Let me look at the time. Yes, it's just about time to stop. Remember your NRTIs, tenofovir, lamivudine, emtricitabine, abacavir. Those drugs have no interaction at all with TB drugs. So if someone has TB, tenofovir, you don't adjust the dose. Abacavir, you don't need to do anything. If your patient is taking dolutegravir, you need to increase the dose to 50 milligrams per Os BD. Never forget these things, guys. If you miss to adjust the dose, we create more problems for our patients, right? Efavirenz, I think it's always preferred in TB because it's one tablet daily at night, and you don't need to make any dose adjustments. So I always prefer it in that space. Nevirapine, never give. You should never find a patient, and I've seen these patients in TB wards where a patient is taking rifampicin and nevirapine. It's a no-go area. They will get liver toxicity, but also fail the regimen, right? If it's lopinavir, ritonavir, what you call Aluvia or Calitra, right? You have to double. Remember, the normal dose without TB, it's 400 over 100 milligrams per Os BD. That's the standard dose without TB. In the context of TB, you have two options. You either double the dose. You can only double the dose of tablets, remember, 800 over 200, or prescribe additional ritonavir, as is the case here, right? So these are two options, double the dose or super boost in the context of TB. Luckily, our patient does not need lopinavir, ritonavir. We have to decide between DTG and efavirenz. That's what we need to decide. Efavirenz, I think, is the best. Stockrine, as we used to call it in the olden days. If there was no contraindication to tenofovir, right, we would give a fixed dose combination that would have tenofovir, lamivudine, and dolutegravir. Then they will take the FDC at night and add additional 50 milligrams in the morning, so that your DTG is 50 milligrams in the morning, 50 milligrams at night, and so on. Efavirenz is best because you don't need to do any dose adjustments. She would get tenofovir, emtricitabine, and efavirenz. So unfortunately, for our case, we won't be able to give any of these fixed dose combinations. Why? Her weight is below 35 kgs. We cannot use tenofovir for patients with low weights. Therefore, abacavir with lamivudine and efavirenz is the best regimen for our case. So we don't even need to deal with that. Yay. Yeah. So the last slide for tonight is don't miss the patient. Sometimes we focus on the complex things, TB this, hey, INH, hey, the drugs this. We miss the person who's in front of us. So don't miss your patient. Appreciate them. We need to support them. We have to be compassionate We have to respect them. We have to preserve, their rights to access information, the right to participate, in these complex decisions, as I was sharing with you now. So just remember the counseling, the support, the grant. Some of us, we don't like the grant, but for our patients, that's all they have. Some of them are unemployed, and so on. So the support, they bring in the partner on board. Gender-based violence, how our country is with this issue. So let's provide the support, and remember that it's too much to take for our pregnant woman. Just to summarize the case of Tumelo. Tumelo is 34 years old. She is 8 weeks pregnant. She has TB symptoms. She's got a CD4 count of 2, right? And then we need to help her. So there are prophylaxis therapies that she needs to take. It's a tick. She's got an opportunistic infection, angular cheilitis. You'll treat it with nystatin or even dactarin oral gels. It's a tick. Because of that angular cheilitis, her World Health Organization staging, she's stage 2. It's a tick. Now, in preparing her for her ARVs, we need to treat her comprehensively using BANK in terms of pregnancy side of things, and then using your HIV guidelines or even adult primary care in terms of the HIV side of things. You do your baseline tests and assessments, and then you assess whether she's someone who's able to start treatment today. We had decided that no, not today. She will be investigated for TB. She will be given fluconazole prophylaxis at least for 2 weeks. At 2 weeks, we start her on ARVs. Because of her weight, which is below 35 kgs, we cannot give her tenofovir. Therefore, we opt for abacavir, for example. Lamivudine is safe. Then we have to choose between dolutegravir and efavirenz. She's in her first trimester. She's between 8 weeks and 10 weeks pregnant. She's taking another drug which can cause teratogenicity. So we opted to avoid dolutegravir and we opted for efavirenz. So we will give her abacavir, lamivudine, and efavirenz. So that's how, we approach these cases. Not very complex, but this case helps you to understand how the different sections in the guidelines come together more than half the time in one patient. It might not be in the same day, but as your patient, things change, her social status changes, her clinical situation changes. You need to be able to identify risks and know when to stop which drug, when to switch, but also importantly, when to refer. By the way, this case, if you feel overwhelmed now, it's okay, because one of the key things in healthcare is to know when to refer, right? So if you feel like, oh, this case, no, doctor, just talk to your doctor. But remember, you need to read the guidelines so that you can help the doctor also on how to effectively manage this case, right? So yeah, so thank you very much for your time. Luckily, I was not speaking alone, which is a good thing because you guys have been quiet. So my time for talking is about to expire. So there are like some number of comments. So I'm going to then, before you start commenting, I'm going to maybe go through the comments and clarify a few things. So she says, with the previous guidelines, if a patient had received IPT for 12 months before, they were no longer eligible for, yes. So even now, they are not eligible unless they have a contact. So if you give me INH prophylaxis therapy, I take it for 12 months and I'm sorted, you can never give it to me again. But if after 2 years, my wife is diagnosed with TB, right? She stays with me in the same household, I'm HIV positive, I'm at risk, right? You therefore have to consider giving me a prophylaxis because I'm at risk of getting TB at that point in time. And then someone says, what happened to patients who are symptomatic and the crack antigen is negative when they do the LP result? Okay, so you have excluded, if you remember on the algorithm, right? Let me show you quickly. That's a very important question. I want to show you on that because she's asking about this specific slide. Where is it? No. Let me go. Yes, she's asking here. So the patient was yellow. She had symptoms, right? You referred for a lumbar puncture, which came back negative. Do you see? What do? You still give the prophylaxis. So there's a pathway for a negative lumbar puncture. So that's very important in terms of that. And then